I mean, that looks like the Last Supper in the back of the room. What's that all about? Hold that for later. You might want to do it again. Anyway, let me tell you guys how this all started. As many of you know, there's been talk about adding ketamine to the truck. So the way this talk originated was I'd been previously asked by Jefferson County to talk a bit about ketamine. It's more about education about ketamine if you don't have a lot of experience with it. Very interesting medication, very interesting effects. And if you've seen those effects, it is very, very impressive. So I did that originally with the topic being something called Excited Delirium. So you can say, what is Excited Delirium? What's that all about? I think we've all seen it. It's the person that's using the bath salts. They're very agitated, they're very confused, they're very diaphoretic, and it's hard to get those guys under control. So, title is ED and how it affects all of us, and of course it's not that ED. And
this is your last chance. You take the blue pill. The story ends. You wake up in your bed and believe whatever you want.
you're taking a lot of blue pills.
I see green when you do that.
So, Excited Delirium. The official title is, it's a state of extreme mental and physiological excitement characterized by extreme agitation, hostility, hyperthermia, exceptional strength without apparent fatigue. Again, think of it as a prototypical person who is using bath salts. That's what we're talking about. You can see it with other drugs as well, but just again, the bath salts person is the person that we're seeing more and more these days. So simply put, think of your sympathetic nervous system, your autonomic nervous system being put on overdrive. So what are you going to see? You're going to see they're going to be tremulous, they're going to be very diaphoretic, they're going to be very agitated, very confused. So think of your fight or flight response in overdrive. Suddenly that is what these people are exhibiting. Their body can maintain that only for a limited amount of time. That's not something that can go on and on and on and on. So as a result, think of it almost as if I get in my car. I mean, I'm teaching my daughter to drive. She hasn't quite got it yet, and she floors it in neutral and holds it there. You know, your car is only going to keep that up for a short period of time before the engine blows. The same sort of thing applies here as well. So it was first described back in 1849. It was by this Dr. Bell. He called it a disease resembling advanced mania with fever, often distinguished as an overlooked and often unrecorded malady. The thing that's interesting about this is that back in the 1840s, 3 out of 4 people died. Okay? Now, here's the scary part. That's still true today. Exactly. So, rose to prominence really in the 1980s. That's when you saw cocaine sort of take hold of the country. You started seeing more and more cases like this. You can see it with also amphetamines and of course the bath salts as we've talked about. These guys are usually young adult males. They usually have some mental illness maybe that they're trying to treat with drugs on board. These are the guys that you're called to the scene that the police have subdued. They're tasing them, they've got them handcuffed, and these guys are the ones that die unexpectedly. You don't expect it, then suddenly, oh my God, how do they die? What happened to them? So, post hoc ergo propter hoc. Essentially what that means, if 2 events occur, one event occurs after another, then the first event must have caused the issue. So this is a real issue, mostly for the police departments. These guys are the people that are dying in custody. They were agitated, they cuffed them, they put them in the jail, and suddenly they're dead. What happened? Lawyers have really seized on that and said, my God, it had to be the police's fault. It had to be something they did. Even though we can document that cases like this have occurred since the 1840s. Nonetheless, it happens.
Your hand's on your head. It's on your head. It's right up there. Oh, yeah, come on. Okay, watch your step. Door.
Oh, man, what can you see to find my hat?
No, Posse, it's on your head. Your hat's on your head.
Right. You have been shot with a tranquilizer, Doug.
Oh, no, but I dozen once and the walls started melting, so I feel you, bro. Yeah. Bro.
So, sorry. I love that. So, currently, estimates say that about 200 people die per year. And it depends on where you look. It could be as high as 600 per year. Again, unexplained deaths. We have no earthly idea what happened. Here's the really scary part. As I alluded to, 77% of those people, they die. They die in the back of an ambulance. They die on the scene. They die in the hospital. And again, it's very unexpected. They go from incredibly agitated to suddenly dead. So again, we talked about this already, often in restraints. They're often young males. They're very commonly have mental illness. And then just before they end up coding and arresting, they end up having a very calm period. I think we've all seen that. The very scary times when we have very sick patients that suddenly die. These guys have that very typically as well. So in terms of criteria, don't try to memorize this. It's just to give you kind of an overview of what these patients look like. Increased pain tolerance. They're very tachypnic. They're very diaphoretic. They typically have a very high body temperature as well. Police noncompliance, again, they're usually hogtied trying to hold them. The inappropriate clothing, they tend to be hyperthermic as well. They tend to have a fever, 103, 104 degrees. Because of that, they tend to strip naked. For whatever reason, somebody focused on the fact that one of the criteria is that they have an attraction to mirrors. I have no earthly idea. But anyway, they apparently like staring at themselves. But 6 out of 10 qualifies as a diagnosis of excited delirium. So there's lots of different theories about how this happens, why it happens. First of all, metabolic acidosis. If you've got someone who's incredibly agitated, they've revved up their body status, they're moving around constantly, there's constant muscle contractility, they're going to develop an acidosis. Remember, in diabetics, when they have ketoacidosis, that's a metabolic acidosis that kills them. That can happen here as well. Again, it's only a theory. Yes, sir?
I see a bunch of things on here, possibly could be actually, how much would brain exhaustion play in these patients?
Oh, it certainly could. All of this right now is theoretic, absolutely. All of this is just guesses. No one really has a good idea of why it happens.
Cause you folks, and it's the heart rate's up, causing agitated and all that, so if you address the heart issue also, would that not help a little?
Actually, believe it or not, the agitation part, the whole thing, we're going to try to address with this. Again, if you've not seen this stuff work for a case like this, it is incredible. I know Megan in particular has seen some of these cases where we have incredibly agitated people. It is amazing. 5 minutes after this agitation, they're sedate, they're calm. They're not sleeping, but they're having a huge trip. So that's sort of what some of the hospitals, especially in Chicago, have been using this medication for several years as a means of trying to, number one, buy time, number two, help you control these patients. Because I can't imagine being in the back of a truck with some of these guys. No way. So let me cover the rest of it. As far as other things that are thought to cause it, of course, if they overdosed on something, perhaps the medication that they overdosed on could have caused the issue. Rhabdo from the, again, continual muscle twitching irritation can cause, generally that's a long-term issue, but it can cause hyperkalemia. It can certainly cause kidney failure. That's not going to kill you immediately. The high potassium could also cause electrolyte changes, which can cause, of course, heart arrhythmias. And of course, there is also the thing that lots of suits have been brought against the police departments is the positional asphyxia. That is when people are restrained with their arms behind their back and their legs up. There's thought that they're not taking a good deep breath, and because of that, they end up asphyxiating. As far as things that can look like it, we've all seen it. Cocaine, certainly other drugs as well. Again, we use bath salts. Neuroleptic malignant syndrome and acute serotonin syndrome. If you're not familiar with those, if you use medicines, people use medicines like Haldol, Geodon. Sometimes that can cause a very excited state as well. People can get very agitated, certainly confused, diaphoretic. It looks very similar to these. But the thing that's important about this is that the medicines we use currently to help treat this condition can actually look just like it. Heat stroke, of course, we've all seen those guys. Very diaphoretic, very hot, very confused. They can look similar, as can people with a very elevated thyroid level, T4 level. So how's it treated? First of all, fluids. They have an acidosis, we want to correct that acidosis. We also want to aggressively cool them. They have a temperature of 104, 105 degrees. Again, we're trying to turn off some of the processes that may actually end up causing them to die. You can even treat the acidosis with bicarbonate as well. And then hyperventilate. If you have that patient intubated, you think they have an acidosis. Again, we all know that it's only a temporizing measure, but you can help correct an acidosis partially by hyperventilating a patient. There's always prayer involved as well.
Titi Vandana, Vandami Tetiyam Sattvam, Sabbakane Supapikitam.
I think that's it. Sorry. So, what are we doing today? So if you look at current state, if I'm sitting in the hospital, or if you guys are in the field saying, what can I do? Currently, what we do is one of two things: benzodiazepines and neuroleptics. Benzos you're all familiar with. Benzos like Valium, Ativan. The problem is twofold. Number one, it takes a while for that to work. If you're struggling with a patient in the field, you don't have 30 minutes to give them a shot, run away, and hope that they end up being sedate. The other thing is that it's variable. You've all seen someone that's taken 2 milligrams of Valium and been out for a week, versus taking 2 milligrams and saying, what you got next? The other side is the neuroleptics. That's our Geodon and Haldol. That's what we use in the hospital very commonly. But it's also pretty common that we give those medicines and nothing happens. 30 minutes later, what do we do now? Nothing's working. And again, as I mentioned, the other problem with these types of medications, it can cause QT prolongation. So you actually have sudden death that occurs with using those medicines as well. It's rare, but it does happen. So what would you want? If you want an ideal sedative, if you want something to get things under control quickly in the field, you want something that's rapid onset, single dose, minimal effect on the heart rate and blood pressure, and easy to administer.
Failed, impressively failed. One toxicology analysis revealed ketamine. That is a very powerful sedative.
Sedatives are used all the time, doctor.
Well, this one's used on horses.
Some of these guys are pretty big.
It would normally take 18 months to psychologically pre-screen viable subjects for space travel. We have seen evidence of a wide variety of territorial aggression.
Can they physically survive the trip? That's all I need to know here, okay?
Personally, I don't know how they survived the tests.
So, as far as ketamine is concerned, it's similar to PCP, it's similar to angel dust. So they're going to get a high. They really are going to get a high. But it's not nearly as toxic. It's used for a variety of reasons. We're going to talk about RSI momentarily, but they use it, of course, as a sedative. Some places are using it for pain relief. Now that's specifically, right now, the cutting edge stuff is they use it for migraine headaches, but that's sort of beyond what we're going to talk about today. Here's the thing. When you give it based on weight, and it's 4 to 5 milligrams per kilogram, IM. You can give it through clothing as well. Pull it up in a syringe, give them a shot. So, of course, everything has side effects, right? So when you look at side effects, hypertension, someone's blood pressure can go up. Now, if you think about it, that's not necessarily a bad thing. Think of the medicines we use today, Versed. What is one of Versed's worst effects? Versed causes hypotension. That's a big deal. This increased intracranial pressure has certainly been labeled with using ketamine. So if you have someone with a head injury, might not be your first choice if you're going to intubate a patient, let's say. I will say this is very controversial, okay? There's not a lot of agreement on that, but nonetheless, it's been labeled, so please be careful. Hypersalivation, hallucination, and then they'll have bronchospasm. A couple of other things. Hypersalivation is probably the biggest issue you'd run into in the field. It's not very common, only about 1 to 2% of patients, but if they salivate a lot, you need to make sure that they can clear their airway. That's a big deal. Bronchospasm can occasionally happen, but what is absolutely true about the medication is that it has actually been found to be beneficial in patients that may have bronchospasm or asthma. So while it may occasionally cause bronchospasm, this is actually considered one of the treatments of choice if you have to intubate, let's say, an asthmatic patient. And then finally, the most famous thing it's known for is the emergence reaction, the confusion that happens.
Hey kids, what's up? How'd it go, Matt?
It went good.
Did your arm feel bad?
It feels good.
Good.
You know?
I know.
So it wasn't so bad going to sleep, was it?
Is it good? Going to sleep's awesome.
Oh, good. I feel dizzy.
Do you?
Why do I feel dizzy? Dizzy. Stupid dizzy. I hate dizzy. I hate dizzy medicine. Yeah. You know, right? I hate stupid dizzy medicine. I'm so dizzy. Dizzy. Hey, Didi, where are you?
Right here.
Hi, Didi.
Hi, sweetheart.
Why is there two of you?
Because of the medicine.
What? Hey, Dad.
What?
What's up? What's up, man?
So, man.
Hey, what's this big... Hey, what's this big orange thing on my arm, man? Come on. It's heavy, you know? I just farted. You know what I'm saying?
So that's an emergency reaction. So advantages, number one, rapid onset. I'm not kidding. When I say 5 minutes, it really is truly 5 minutes. I can remember a case in particular I had in the hospital. There's a fella who was hypoxic. He had a stat in the mid-80s, definitely needed intubation, very agitated, very diaphoretic, could not get a line. He was just moving around so much. Shot a ketamine IM. 5 minutes later, we're getting an IV and I'm intubating. So it can be advantageous in cases where you have someone who is so incredibly agitated. That gentleman was a drug overdose. It can be given IM, of course, through clothing. Duration's about 20 to 30 minutes. One of the things that at least from a hospital standpoint, that we've struggled with is this notion that perhaps it lasts for several hours. It doesn't. It's very quick. The whole point, if you have someone like the case I just told you about, is that it buys you time. If I have that patient who comes in that's very agitated, it buys me time to give them something else. I can give Geodon, I can give Ativan, I can give Valium all day long. That won't work for at least 25 to 30 minutes. This buys me time to get things under control. And the airway reflexes are intact. So in RSI, let's talk about RSI briefly. So you can use ketamine as an induction agent, so that whereas I might consider using, let's say, Versed, I might consider using Accommodate, this is an alternative. It's 1 to 2 milligrams per kilogram IV. In pediatric patients, Harriet Lane listed at about 0.25 to 0.5 milligrams per kilogram IV. Onsets within about 45 seconds. Again, the duration of action is about 10 to 20 minutes. So benefits, again, gives good analgesia. Remember, some of the medicines we use, like Accommodate, you get absolutely no analgesic effect at all, period. It may help with bronchodilation, so if I have someone who has asthma, it may help those symptoms. It may also actually improve the contractility of the heart. I saw that up to date. I didn't get anything to quantify that, so I can't give you numbers associated with it, but that's certainly a possibility. And of course, the concerns, the increased intracranial pressure, again, very controversial, and that reemergence phenomenon. I think that is it.
Wow.
And that's all I have for ketamine, guys. Any questions about that? Yes, sir.
For hallucinations, has been one of the side effects. How do we treat that? Do we treat that with additional ketamine? Can repeat doses be gave? Or how do we handle their hallucinations?
Actually, generally speaking, they're a sedate, kind of benign hallucinations, if you understand what I mean. When you see those patients, normally what they're doing is maybe looking around, talking to themselves. It's nothing more than, the agitation is gone. It is incredible.
And the reason I ask that question is, speaking of other people that have used it for innovation, they have talked about the one problem they had with it is sometimes it could incite excited delirium, so they would just give additional dose to get them to calm and situation. So I didn't know if on the hallucination side if that was similar or not.
You could actually use benzos as well. That would not be unreasonable also.
What was the pediatric dose for induction as well? I didn't get
It's 0.25 to 0.5. That's straight out of Harriet Lane.
What was it again? I'm sorry.
What's that? Yeah, 0.25 to 0.5. But just, I kid you not, it is amazing how well this works. I had a child that was mauled by a dog, had 13 separate lacerations I repaired. One shot of ketamine later, this child woke up, says it was her forget it medicine. She was absolutely sedate and calm. Now, if only 5 times. So I know how difficult it is. So at least I could throw in a photo or two and have a grand finale, so just bear with me. But I'll try not to lose sight. So, I only stuck that in once upon a time. I've had a few openings over time, but I do that just because I know Jamie records these. So, to start.
Report to your stations immediately. This is not a drill. We are under attack. We are under attack.
Here I come to pay the debt.
So again, you guys have been through this 1,000 times. Why do we put in an airway? They have an altered mental state, inability to protect their airway, or they have respiratory failure or arrest. Again, we do rapid sequence intubation because we're trying to decrease the likelihood of airway trauma, increase your chances of success, and of course decrease intracranial pressure. So RSI is done when you need an airway and the patient's awake enough to resist. I've referenced this before, I actually found this picture. So I told you, I had a patient once upon a time that came in after an overdose, and they had that taped to their chest. I didn't know what recitate means, do not recitate, so I stuck them on a ventilator. You see over there, it actually says living will. Let's see if they only spelled better. So equipment, again, I'm not going to bore you with details. You guys know this better than I do. When IV, preferably 2 BVM, supplemental oxygen, suction, laryngoscope, and of course, you know the equipment. You know it better than I. You guys use it every day. In terms of preparation, of course, we try to hyperoxygenate patients. We apply 100% artery breather. We use the high-flow nasal oxygen if we need to as a bridge. And of course, the Sully maneuver, I won't go through all that again. Now, in the past, we've talked about lidocaine. Now, lidocaine, as you know, was thought to have decreased intracranial pressure. Here's the problem. I read a study, as a matter of fact, I was doing some CME recently, and they were referencing a study a few years ago where they actually put probes in pigs' heads. And they found that it really made no difference. If you look at up to date, they'll say it's controversial. It's not really been shown to make a difference. So from my standpoint, it should just go away. It's not been shown to make a difference. Why use it? Does that make sense? We've done it forever, but nonetheless, it doesn't show any real benefit. The other thing is atropine, and as Todd has pointed out before, recommendations have changed. The only current recommendation they talk about with pre-intubation in kids is that if they're less than 5, getting succinylcholine, or if they're over 5 and getting a second dose of succinylcholine, that they probably should deserve atropine. In terms of adjunct drugs, we have etomidate, we have Versed. As you guys know, etomidate is a non-barbiturate sedative hypnotic. It doesn't provide analgesia. For every 0.1 milligrams per kilogram they get roughly 90 seconds of sedation. Comes with a couple of issues. The biggest, of course, is about a third of people have nausea, vomiting. About a third of people have clonus. Versed, on the other hand, is a sedative amnestic. It's a benzodiazepine, but it can cause significant hypotension, which is how we got to ketamine in the first place. And you know what? That's not a half bad photo. You could probably sell it, make that work.
Oh, wow.
So, ketamine, as we talked about earlier, 1 to 2 milligrams per kilogram IV as an adult is an induction agent, and 0.25 to 0.5 milligrams per kilogram is an induction agent in kids. Onset's about 45 seconds and it lasts 10 to 20 minutes. You then take your paralytics, and if you compare the two, succinylcholine versus your vecuronium norcuron. So succinylcholine, of course, is a depolarizing muscle relaxant, and because of that depolarization, people have a tremor, and that causes, of course, certain problems, increased intracranial pressure. It can cause problems with hyperkalemia. So people that have eye injuries, major trauma, muscle injury, you have to be incredibly cautious. Of course, the problem with vecuronium has been its long duration of action. So if I can't get that tube, I'm going to be bagging them for about 25 minutes or so. There's something I'm going to mention, not that we're going to do anything about it today, but I want you guys to be aware of it. I'll mention that in just a moment. And of course, we use a non-depolarizing dose of vecuronium oftentimes when we're giving succinylcholine to help obviate some of those effects with an increased intracranial pressure spike. In terms of a protocol, again, hyperventilate the patient, evaluate for rhythm, pulse oximetry, have that IV established. So generally speaking, you pick one of the sedative medications, you pick a paralytic and you use them in conjunction. We've all seen the patient that's already done enough to themselves that it's not hard, you can intubate them without having to use those types of medications. But nonetheless, sedative, hypnotic, and then followed by paralytic. In terms of contraindications, it's just because of hypersensitivity to medications. Prolonged paralysis in patients, specifically you're using succinylcholine, and of course if you don't have an alternative airway. So I just put this in just for reference sake. You guys may already be very familiar with it. Sugammadex is actually a reversal agent that's used for the long-acting paralytics like VEC and rocuronium. So it's just brand new. I know that even the hospital has been talking about at least having something like that on hand. One of the issues with using something like vecuronium as a primary agent is that you were concerned about that long duration of action if there's an issue, but you're starting to see it emerge. Again, don't imagine that's going to be on the truck anytime soon, but at least I want you guys to know that that is out there. So intra-procedure requirements, of course, look for cardiac arrhythmias, look for hyper and hypotension, tachycardia. And as far as once that tube is in place, you make certain that they have it in place with an end-tidal CO2 detector. Then you would administer your long-acting sedatives. I call that the fox and the hound. Ha! Oh, come on, that's not bad. Not bad at all. So in terms of confirmation, 2 ways, capnography and pulse oximetry. Pulse oximetry, remember, only measures oxygenation. Capnography is incredibly important. People lose sight of how incredibly important and how valuable a tool capnography is. So it not only looks to see if there's CO2 present, but it also can measure that. And you get a standardized waveform. So when you look at the wave, Inspiration starts here, expiration starts there. And you can use that picture to get some idea of how that patient is doing and see if there's other measures that you need to take. So, a typical waveform is going to have sort of a mesa type of appearance. And usually that CO2 is going to be somewhere between 35 to 40, just like it would be on a blood gas. So,
It ain't got no gas in it.
if it's in the esophagus, you're going to get a flat line. If it could be not necessarily a 0, it may be at 5, 10, but certainly it's going to be flat. You're not going to see that undulation with normal respiration. If you dislodge it, suddenly it's going to disappear. Normal appearance and then disappear.
No, you're doing it all wrong.
So, with COPD and asthma patients, again, think about your asthma patients. What are they doing? Those guys have the pursed lip breathing. They have the expiratory phase is very prolonged. So as they're trying to exhale, you get the so-called shark fin appearance. And that could be an indication to you, hey, this is an asthma patient. Because being in the field, I can imagine how incredibly hard it is to tell the difference. Do I give them Lasix? Do I give them breathing treatment? Should I give them steroids? What should I do? This would be an indication that, hey, that patient probably deserves maybe a bronchodilator. Give them albuterol. I'll get rid of my fish picture eventually. So CPR waveform. When you perform CPR, you're going to get the same type of waveform. You're going to see that that number is going to be a lot lower, of course, because that patient doesn't have a normal metabolism like everyone else that's walking around. So when it drops to less than 10, that's when you would consider changing rescuers. Now here's what's interesting, and I referenced a little bit later. You will see that baseline increase. That baseline will start climbing as the patient is improving. So even before you get a pulse back, you'll see that improve. One case in particular, I don't know, it's probably been a couple of years ago, we took to the cath lab. Mark Potts was actually just happened to be there at the ER at the time. So it was a patient that kept crashing. CPR briefly, medications, we would get them back. What was interesting is while we were in the cath lab, one of the cath lab nurses says, I can't find the pulse. Mark, very astutely, is looking at capnography, nothing else, not touching the patient. He said, I think you better check again, because you got a CO2 of 35. And he was right. The patient did have a pulse. You're going to see this improve before you find that the patient clinically is improving. If you have a rising baseline, that is, as that baseline is increasing with each breath, what that means is you're not allowing enough time for that patient to exhale. So I'm stacking a breath on top of each other. And because of that, they're not exhaling. Therefore, I'm not pumping out my CO2 as I should. When you have a tube or cuff problem, it's just the opposite. Think of it as the opposite of what we saw with asthma earlier. That is, at the beginning of this inspiration phase, that it's prolonged. So imagine trying to breathe through a straw. It's going to take a while for that to reach a plateau, that I'm getting maximal air input. And that's what you see here. You can also see that if you have someone with a tube or a cuff problem. With hyperventilation, the only difference is they're going to be short, they're going to be rapid, and your CO2 is going to be less than 35. And you'll see this, of course, with patients that have DKA or any other type of acidosis for that matter. Last bit I'll go over is, of course, the curare cleft. You can remember, this is the start of inhalation. So this is me pushing a breath in. The difference is that's that patient resisting you. So as you're breathing for them, they're trying to overcome that and exhale. That's the so-called curare cleft, and that's a sign that the patient needs additional paralytics. So, I referenced this a few years ago. I bring it up every time. That was a study that came from pre-hospital disaster medicine in 2011 that demonstrated that when you start with a porous CO2, that patient may not have a very high likelihood of surviving.
Oh my God! They killed Kitty! You bastard!
So in terms of want to make it, again, you're going to see that improving before the patient clinically improve. So it's something to actually watch. It's, in terms of, let's say you can't get that intubation, of course you're going to try for a repeated attempt, assess your level of sedation, certainly hyperventilate them to make sure that they're not hypoxic, and even consider someone additionally trying as well. So you guys go through this, you have several different alternatives, such as the comba tube, of course the bougie, the salt airway, etc. The nasal cannula is a bridge. I'll just, again, rush through. It has been shown to be very beneficial even in patients that are not breathing spontaneously. Again, it dates back to a study in the 1950s with an ENT who was brave enough to put patients on high-flow nasal O2 and did his work on their mouth and throat without any bagging attempts. So they were sedate, unconscious, and he was able to do so without becoming hypoxic. Finally, of course, the cricothyrotomy. So again, if you've never done one, the cricohyoid cartilage, of course, is in your neck, and if you feel there's a little notch in your neck, that's the cricohyoid membrane. So the most important thing, of course, is to make certain that they're sedate. Number one, if they are conscious. Generally speaking, it's controversial, and I have a little video here to demonstrate. But most would suggest a vertical incision initially. It's very important that you hold it in place, because what happens is some of the tissue underneath will shift if you don't hold it. So once you grab a hold to make your initial incision, don't let go. It's a vertical incision about 3 centimeters in length. You expose the cricohyoid membrane, and then it's a horizontal incision afterwards. The reason that most, even though the presenter in the video sort of dismisses the idea that most like the vertical incision is because about 10% of people have an anterior thyroidal artery which can bleed a lot. So initial incision is usually vertical, into the hyoid membrane is horizontal. Oh, right. So, already covered that. In terms of complications, you guys aren't concerned about complications in a minute where it's just life or death. I need to get that airway in. Hematoma can form, of course, aspiration of blood can form. You can have a laryngeal stenosis. Again, that's a long-term issue that these patients may suffer, and of course, an esophageal laceration if you go too deeply. So I apologize for this video. I promise it is dry, it's dull. It's about 4 minutes. Bear with me through this. I have a couple more pictures I want to show you, one of which I'm pretty proud of.
At the end of the video, the participant should be able to, number 1, identify the surface markings and structures to be noted when performing a surgical cricothyroidotomy. Number 2, describe the indications and complications of surgical cricothyroidotomy. Indications for surgical cricothyroidotomy. Number 1, inability to visualize the vocal cords. Number 2, severe maxillofacial trauma with resultant distortion of the normal upper airway anatomy, or bleeding resulting in an obscured view of the vocal cords. Number 3, strict immobilization of the cervical spine is required. In terms of the required equipment, a number 11 blade, an airway in the form of either an endotracheal tube or Shiley tracheostomy, varying sizes from 4 to 8.0, a 10 cc syringe to allow for adequate inflation of the tube cup, where available, suction, prep, and an O2 source. In terms of patient positioning, the patient should be in a supine position with their head in a neutral position. If there are no concerns for an unstable cervical spine injury, then the patient may be placed in an extended or sniffing position. Prior to inserting the definitive airway, the cuff should be inflated to ensure that it is intact. From the standpoint of the approach and exposure, the operating surgeon should stand on the right side of the patient. The key step in this procedure is palpating the cricothyroid membrane, which is located between the thyroid cartilage superiorly and the cricoid cartilage inferiorly. Prior to creating an incision, it is important for the surgeon to stabilize the tracheal-laryngeal complex with the left hand. The incision should be placed directly over the cricothyroid membrane using a number 11 blade. Technical points. There is debate among surgeons with regards to the optimal type of incision, whether it be vertical or horizontal. Advocates of a vertical incision state that it is an extensile incision and may help to avoid iatrogenic injury to the anterior jugular veins. Those that advocate for a horizontal incision state that a single incision may be created, which is taken through the skin as well as subcutaneous tissues and directly into the airway, thereby avoiding two separate incisions. Difficulty may be encountered upon inserting the actual endotracheal tube or tracheostomy. To this end, the handle of the knife may be inserted and rotated 90 degrees to create a larger opening within the actual airway. Alternatively, if available, a hemostat or tracheal dilators may be inserted into the cricothyroidotomy and then spread, thereby allowing easier insertion of the definitive airway. If insertion of an initial endotracheal tube or tracheostomy proves difficult, then inserting a tube of a smaller diameter may also be beneficial. Complications of surgical cricothyroidotomy may be classified as immediate or delayed. Immediate complications include iatrogenic injury or laceration of the anterior jugular veins, the trachea, or the esophagus. Creation of a false passage into tissues may delay the procedure and be associated with significant hypoxemic complications. Aspiration is always a possibility with this procedure. Delayed complications include subglottic or laryngeal stenosis, hoarseness, vocal cord paralysis, post-procedure management. It is crucial that once the definitive airway is obtained, the tube be secured. Due to the high likelihood of aspiration in this setting, a post-procedure fiber optic bronchoscopy is highly recommended both for tube conformation as well as for secretion clearance.
I will see if I can speak in a monotone as well.
It'd be fun to hang out with, wouldn't it?
I tell you, oh my God. So, that's all I have. So I'm going to play my game I played last time. I heard it in the ER. So he's not here today, but I heard one of the paramedics was naming their recent upcoming personal shopping list, including fishnet stockings, a corset, and garter belts. Who is this paramedic? Yes.
No.
Now, I gotta admit, I could not bring myself to Photoshop that, my God. But I did Photoshop this. So just bear with me, watch for the transitions. So, that is where I will be in 24 days. So I'm very much looking
Do you
forward
want
to that.
sympathy or what?
I'm telling you what, I haven't had a vacation in
Where
a
you going
long
to?
time. Disney cruise out of New York, down the East Coast.
Yeah, Kevin Clark.
Going to Bermuda?
Actually, no. One of the stops, though, is going to be at Port Canaveral, so you go to Disney World on a day trip. So that's actually kind of cool. Any questions, guys? I know you guys know this, so I apologize, but I spent a little time on my Photoshop at the end, so I had to show it. That's all I have. Thank you, guys.
Thank you.